Good evening. My name is Chip Sander, and I'm the president of the board of directors of the Epilepsy Foundation of Colorado. It's my pleasure to welcome you to the Epilepsy Connect Symposium. We'd like to thank Eisai, one of the world's leading pharmaceutical companies, for sponsoring this symposium. Eisai's mission is to give first thoughts to patients and families. In furtherance of that mission, Eisai is making it possible for the foundation to connect and educate the epilepsy community in Colorado by means of this symposium. The mission of the Epilepsy Foundation of Colorado is to empower, connect, and educate in order to improve the lives of everyone affected by epilepsy. And this symposium is a critical part of that mission. Earlier today, we held a seizure first aid certification course to kick off the symposium. Education is key in creating a safer world for those who are impacted by epilepsy. To that end, we've got a great week of very informative webinars ahead of us. As you probably know, 1 in 26 people have or will have epilepsy. Like many of you, we have a family member with epilepsy. In our case, it's our son. You may also be aware that there are nearly 60,000 Coloradans living with epilepsy. Please know that you are not alone, as evidenced by the fact that over 300 people have signed up for this symposium. Your participation tonight and throughout the week represents your commitment to advocating for individuals with epilepsy, battling the stigma, and raising awareness for this community. We recognize it's been a very challenging year, but by participating in this symposium, we can be together despite being apart. So thank you for being here and connecting with us. We can't wait to be back in person with everybody. And please know that the foundation will be here for you no matter how difficult the circumstances. Again, thanks to Eisai. And now we'll watch a short video about Eisai.
Hi, everyone. Welcome to the third annual Epilepsy Connect Symposium. My name is Sarah Klein. I am the CEO of the Epilepsy Foundation of Colorado. It's my privilege to welcome you to this conference that we host annually. I wish, like Chip said, that we could be together in person, but I'm so glad that we can still be together through the miracle of Zoom technology. We call this the Connect Symposium because our primary goal is to connect with you and to connect you to each other, and to connect you to resources and to healthcare providers. And offering this conference virtually enables us to provide access to even more people than ever before. And this week, we are showcasing the brightest minds in epilepsy research and treatment and lifestyle so that you have access to the knowledge that you need to make the best decisions for yourself and your family and those in your care. At the end of the week, we hope that you feel empowered with new knowledge, new resources, and new connections so that you're ready to take the next step in your journey with epilepsy. We couldn't offer this conference without the generous support of our sponsors, who I want to thank before turning things over to our keynote speaker. Of course, I want to thank and acknowledge our presenting sponsor, Eisai. We're so grateful for your generous support. I also want to thank SK Life Science, who is sponsoring our opening keynote session today. Thank you, SK Life Science. I also want to thank each of you who made a generous contribution when you registered for this conference this week. You did not have to make a donation, but we are so grateful that you did. As Chip mentioned, this has been a challenging year for the Epilepsy Foundation, as it has been for many nonprofits, and as it has been for many families. And we're really, really tremendously appreciative of your generosity when you made a gift upon registration. So thank you to you who are also sponsoring this, this conference. We're really grateful. So to our sponsors, our volunteers, our donors, we are grateful for your generosity and your commitment to helping us connect, educate, and empower to improve the lives of everyone affected by epilepsy. Thanks for being here with us tonight. It is now my pleasure to introduce our opening keynote speaker for this week's conference, Dr. Danielle McDermott. Dr. McDermott is a neurologist and epileptologist at the University of Colorado Anschutz Medical Campus, where she completed her neurology residency and epilepsy fellowship. Dr. McDermott serves as the medical director of the Epilepsy Monitoring Unit at the University of Colorado Hospital. She has served on the professional advisory board for the Epilepsy Foundation of Colorado for many years and was recently nominated to the National Epilepsy Foundation's Professional Advisory Board as well, where she serves on the advocacy committee. Dr. McDermott's focus in clinical care includes surgical epilepsy and surgical evaluation for patients living with medication-resistant seizures. She is active in multidisciplinary specialty clinics, clinical trials, quality improvement, and clinical outcomes research. Dr. McDermott believes in a multidisciplinary approach to patient care with a strong focus on behavioral health and patient education. Her goals are to promote quality of life and incorporating aspects of integrative medicine. I can't think of anyone better to address this most timely topic of epilepsy and COVID-19. Please join me in welcoming Dr. Danielle McDermott.
Thank you, Sarah. That was a very nice introduction. It's nice to be with everyone this evening. I wish I were with you in person. It's a very timely talk this evening. I'm going to try to share my screen. So, Sarah, can you see my screen?
Yes, I can. Thank you. Great.
Okay. So you're here to hear me talk as a non-virologist about COVID-19, but specifically about COVID-19 and epilepsy and what we do know. So I'm going to go and give some background in terms of virology. I'll talk about COVID-19 and COVID-19 risk factors, specifically about what we know in terms of epilepsy and epilepsy-specific risk factors. What we know about COVID and seizures, medication-related considerations, specifically what we might consider in terms of diagnosis, treatment, and prevention, how we can prepare and plan. And then I'm going to talk some about the secondary consequences of COVID-19 as it applies to people with epilepsy. So a astounding figure here from the Johns Hopkins database. The number of COVID-19 cases we know has skyrocketed recently. And as of last night, there are over 160,000 known cases of COVID-19 to date in Colorado. Over 10,000 Coloradoans have been hospitalized. Over 2,500 Coloradoans have died from COVID-19. The mortality rate is now 1.6%. So taking a step back, I thought it would be useful to review some virology. I call this Virology 101. So what is a virus? And so a virus is different than a bacteria in terms of its the way it infects what we would call a host. So the host can be a person, a plant, or an animal, and it relies on this host in order to reproduce. So during an infection, a virus will insert its genetic code, either RNA or DNA, into its host and use the host to replicate itself. And then it makes its host sick. So in the case of a respiratory virus, it will cause its host to cough or sneeze, and then in order to then infect other hosts. So when infected, the host will then activate its immune system in order to try to mount a defense. So if a host has previously seen the virus, or perhaps has been immunized by a vaccine, then the host may already have antibodies and then be able to mount a defense towards that virus. However, if the host has never seen a virus, or if the virus has significantly changed, the host will have to mount a new defense against a virus. So how about coronavirus? Coronavirus refers to a large family of viruses that can cause illness either in human or animal hosts. There are actually hundreds of known coronaviruses. So in humans, there are currently 4 types of coronaviruses that will cause symptoms of a common cold. However, beginning in the 21st century, in 2003, beginning with SARS-1, there was actually recognition of these newer coronaviruses that began in animal hosts and then they were spread to humans. So in 2003 with SARS-1, followed by MERS in 2012, we saw the emergence of these novel coronaviruses. And the difference being that they were actually poorly transmissible, meaning that they were not easily didn't easily infect other hosts. The reason being that the host had to become very, very ill for somebody else to become infected. So they kind of went away on their own. Now, in late of 2019, we had the emergence of coronavirus 2019, or otherwise known as SARS-CoV-2. So now we're in the midst of this pandemic that began was traced back to the animal markets in Wuhan, China, back in December of 2019. People began to see newer symptoms and thought that there was something very different about what was going on. In March of 2020, the first cases were recognized actually in Colorado. You might wonder, well, why is this a pandemic? Why is this not called an outbreak or an epidemic? It's all a matter of scale. An outbreak is confined to a small geographic area, whereas an epidemic may be a smaller area like a state or a country, and a pandemic is now that it has spread worldwide, affecting more than 100 countries. It's an emerging infectious disease. We call this emerging because it is moving from an animal to a novel, now human host, who now we have no immunity, as we've never seen it before. In contrast to SARS-1 and MERS, it's easily transmissible. And the reason for that being that many asymptomatic carriers transmit COVID-19. So you don't necessarily have to be sick to transmit this virus. So speaking more in terms of numbers, in infectious disease, the terms prevalence and incidence are used. Prevalence is the number of cases or approximate percentage of the population that is infected. And then incidence is how quickly people can become infected. So the new cases over a time period. So I refer to the number of cases in Colorado as of today, but in the United States, there's been over 11 million cases and over almost 250,000 deaths related to COVID-19, with a mortality percent of 2.2. Worldwide, over 54 million cases and over 1.3 million deaths, with a mortality percent of 2.4. And again, this is related to the Johns Hopkins data. In my research for this talk, and going to this is the Colorado Department of Public Health data, I thought it was very interesting to look at testing rates, testing availability, and testing positivity. And I would encourage you to look at this website as well. If you look towards the the beginning of this graph, where I have this first box on April 19th, 2020, that's when we had the peak of what was called our first wave. And if you look, it shows that over 1,000 people were tested at non-CDHP or Colorado Public Health labs with a 22% average positivity. But in contrast, there were only 25 total tests done per 100,000 people. Now, looking towards today, or just recently, a few days ago, this is astoundingly different. So 35-fold increase of people tested with an average positivity of 12%. And looking at the availability of testing or ability to test is significantly increased. Now, how were we doing, when we weren't in the midst of a wave? In the months of, June through September, you might wonder what were the positivity rates. They were around anywhere to 2 to 3 to 4%. Looking at age in terms of, who comprises the positive cases, primarily it's related to age. So we're looking at the pretty much the 20 to 29-year-old group comprises about 22%, the greatest percentage of people who have test positive for COVID-19. That's followed closely by 30 to 39-year-olds and then 40 to 49-year-olds. You see at the age extremes, there are much fewer positive cases. However, when you look to mortality, you see the inverse effect. You see that deaths related to age are, over 50% are in that greater than 80-year-old group, and then 23% in people who are 70 to 79. So what is the biggest risk for COVID-19? So globally speaking, it would be age over 65 and you might say 70. According to the CDC, 8 of 10 COVID-19 related deaths are in people of 65 or older. And the graph on the bottom talks about hospitalizations, and you can see how hospitalizations increase really, with every single age category as you go up. This is per 100,000 people. In the 50 to 64-year-old group, it's 136. And by the time you get to 75 to 84-year-old, it has doubled. So what medical conditions are considered high risk for developing severe illness related to COVID-19? So on this list, which does tend to change from time to time, is cancer, chronic kidney disease, chronic obstructive pulmonary disease, heart conditions, being immunocompromised related to an organ transplant, obesity or severe obesity, defined by BMI, being pregnant, having sickle cell disease, smoking, and type 2 diabetes. The CDC then goes on to characterize the following conditions as potentially being at increased risk of severe illness. These include moderate to severe asthma, cerebrovascular disease or stroke, cystic fibrosis, high blood pressure, a weakened immune system, that can be related to an immune deficiency or due to medication. Certain neurological conditions specifically mentioned by the CDC as dementia and ALS, having liver disease, being overweight, having pulmonary fibrosis, which is scarring of the lungs, having blood disorders called thalassemia, or type 1 diabetes. Well, I didn't mention epilepsy. So let's first talk about the prevalence of epilepsy. We know that epilepsy affects anyone. It affects children, it affects men, it affects women of all ages, all races, all ethnic groups. Epilepsy is the fourth most common neurological disease. 3.4 million live with active epilepsy. There are 150,000 new cases of epilepsy every year. And as Chuck mentioned, 1 in 26 will develop epilepsy at some point in their lifetime. So are people with epilepsy at a higher risk of developing COVID-19 or severe COVID-19? So we know that no two patients with epilepsy are alike. It is a spectrum. It leads to seizures. Some people have seizures that are controlled. Some people have seizures that are not controlled. But there is no evidence that epilepsy alone will increase the risk of getting COVID-19. And there is no evidence that epilepsy alone will increase the risk of getting severe COVID-19. There is no evidence that people with epilepsy alone will have a weakened immune system. However, it's important to mention that people have different types of epilepsy and that certain causes of epilepsy or other health conditions affect immune system, and that can lead to a higher risk of COVID or severe COVID-19. So what are these factors? What factors increase the risk of COVID-19 for a person with epilepsy? So first of all, there are medications that are taken with seizures that may also affect immune function. So specifically, ACTH, which is a medication that is taken for infantile spasms, steroids or immune therapy, which may be taken for autoimmune epilepsy or for people who may also suffer from something like a brain tumor that may also have seizures related to a brain tumor. However, it's also important to mention that most anti-seizure medications will not affect the immune system. Now, people with epilepsy may have other neurological or developmental issues that place that person at greater risk. So for example, those underlying neurological and developmental issues may cause difficulty breathing or difficulty swallowing. So those issues may predispose to a higher risk of COVID-19. However, it's not that person's underlying seizures that would predispose to COVID-19. A word about disability. So adults with disability are 3 times more likely than adults without disability to have heart disease, stroke, diabetes, or cancer. It's also important to note that limited mobility in a person who has a disability can confer higher risk. So if someone is unable to avoid coming into close contact with others, such as direct support providers and family members, if somebody has difficulty understanding information, such as practicing preventive measures, such as hand washing or social distancing. And if somebody has difficulty communicating symptoms of illness, these would all confer higher risk of becoming infected with COVID-19. So a question that we frequently get as epileptologists is, if I get sick with COVID-19, will this trigger seizures? And people with seizures often know if an infection will trigger a seizure. And this is related to the physical stress of being sick. So a common seizure trigger may be this acute illness or infection that can be caused by a variety of viruses or bacterial infections. So head colds, respiratory infections, and sinus infections. So again, it is the physical stress of becoming sick, having fever, being dehydrated that may lead to a seizure. Also, when you are sick, you don't tend to sleep very well. So having poor sleep when you're sick may also add to that risk of having a possible seizure triggered. So I'm going to switch gears and talk a bit about diagnosing, treating, and importantly, preventing COVID-19. So how is COVID-19 transmitted? It's transmitted by droplets, so it's a respiratory transmission, either inhaled, so if somebody sneezes, coughs, breathes, sings, and these droplets are inhaled. Or if you touch a surface that has virus on the surface and touch your face, rub your eyes, so close proximity and coming into contact with any infected surface. We talk about incubation time being the time that you might be exposed to the virus to developing symptoms. And for COVID-19, that's anywhere from 2 days up to 2 weeks. We also talk about the difficulty with COVID-19, knowing that many people are asymptomatic, and we call this asymptomatic positive. And it's pretty surprising to know that 40 to 50% of people who have COVID-19 may have no symptoms at all. However, the most common symptoms are fever, cough, shortness of breath. However, these symptoms may be very mild and they may be very severe. They may also include body aches, pains, loss of taste, loss of smell, diarrhea. So these symptoms are wide ranging. It's tested for by nasal swabbing for the genetic material, the COVID-19 RNA, which is then amplified in the laboratory. So how are you evaluated and treated for COVID-19? Again, most people are asymptomatic and most people are able to recover at home and have self-quarantine. But how do you know if you need to seek medical attention and go to the hospital? Well, people who have difficulty breathing, any changes in mental status, pain when they breathe deeply, meaning that may indicate a pneumonia, or any concern for changes in oxygen saturation, which can be indicated by any discoloration of the lips or the face. The CDC has a nice resource. It's called the Symptom Checker. And you can go to cdc.gov coronavirus. And it's useful to see if any of the symptoms that you're having maybe should be evaluated. But the treatments that are offered range from supplemental oxygen all the way to having to be mechanically ventilated, meaning having a tube put down into your trachea to oxygenate your lungs. Other treatments that are offered are IV fluids, supplemental antibiotics, meaning that there may be another infection, a bacterial infection that also needs to be treated. And depending on where you may seek treatment, there may be clinical trials where investigational medications are available. So what are some of those medications? They come in 3 main big varieties. They're antivirals. Antivirals stop viral replication. You may have heard of, for example, Tamiflu that is used to treat the flu. The efficacy or how effective these medications are not really well known. And they may have pretty significant side effects at this time. So these are still under investigation. What is commonly used for severe COVID-19 is recombinant plasma. And the way that's done is plasma from somebody who has previously had a COVID-19 infection and has recovered is donated, and then is used to treat 3 to 4 people who have a current COVID-19 infection. There's also the development of monoclonal antibodies. So that's in contrast to that's donated from someone that has recovered and mounted antibodies. These are synthesized in a lab to prevent infection or treat infection. There are also medications that modify the immune response. So specifically, something that's pretty commonly given for severe COVID-19 may be high-dose steroids, for example. So vaccines, there is a global effort for development of COVID-19 vaccines by pharmaceutical companies, academic institutions, biotechnology companies, and governmental agencies. Interestingly, the first vaccine was in development 6 weeks after the virus was first sequenced. Now, there are many, many steps that the vaccine has to go through to become approved and then made on a wide scale. So first, it needs to be evaluated for safety. Then the vaccine needs to be shown to actually mount the immune response that it's directed against. And then it needs to be shown to actually protect against the disease. So who would get the vaccine? Typically from epidemiologic data, as I showed you, who's at high risk. So we need to prioritize people that are at higher risk. And then distribute the vaccine in a global and equitable manner. Today's news showed that we actually have a second candidate for a vaccine by a company that has shown in preliminary analysis that maybe we have a 95% effectiveness in this vaccine, and perhaps would be available by the end of the year. So time will tell. But even though we don't have a COVID-19 vaccine, we do have a flu vaccine. And we do know that children with neurological disorders are at higher risk from flu. And there was, in the 2009 H1N1 pandemic, there was demonstrated that to be very few children that were fully vaccinated for the H1N1 vaccine. However, these children actually comprised a disproportionate number of deaths related to H1N1. So of the 336 children with information available on underlying medical conditions who were reported to have died, 227 had one or more underlying health conditions, and 64% of those had a neurological disorder. Only 3% on whom had a vaccination status available, only 3% were fully vaccinated for 2009 H1N1. So what are some medication recommendations for people with epilepsy and COVID-19? So the first is not to miss doses of anti-seizure medication. If you're sick to your stomach, if you're having diarrhea and can't take your medication, call your doctor or go to the emergency room to get help. Also, be careful about the over-the-counter medications that you take. Some can potentially increase seizures in people who have epilepsy, so it's important to talk to the pharmacist or talk to your epileptologist or neurologist to make sure that you are taking medications that are safe for you. This includes herbal remedies. Some medications can increase chance of seizure or also interact with your anti-seizure medications. It's also important to ask, like, what is safe? So nasal sprays, expectorants overall are safe for cold, allergies, and sinus problems. Take good care of yourself. When you're sick, drink plenty of fluids, eat the best you can, get rest, and take medications that are recommended to treat a fever. So how do we prevent COVID-19? We get lots of messages on distancing, masking, especially if to protect others if we happen to be one of these asymptomatic positive carriers, and also to conduct hand hygiene. But what if you're at higher risk? What should you do? One is to follow the CDC guidelines, which change frequently. So make sure that you're in contact with your healthcare team, and also go to the CDC website. Stay home if that is feasible for you. If a family member you live with were to become ill, is it feasible for that person to stay somewhere else? If that is not feasible, you should have your own room, if possible, to have separate bathrooms and washing hands frequently. It's also important to think about attendance at a work or day program. So if your loved one attends a work or day program, ask about potential alternatives in terms of home activities or small groups. If your loved one lives in a group setting, such as a group home or assisted living, long-term care facility, it's important to find out what precautions are being followed. And if you have concerns, talk to them and see if any adjustments need to be made. Also, if somebody's coming into your home to help you, ensure good health practices are followed. So always keep communication open, talking to any agency or person that comes in, and make sure that you have shared expectations. And always good to have a backup plan for any help in the home. So what is the best way to be prepared? So if you have changes in your seizures, of course, call your epilepsy care providers. I think I've said this probably a couple times now. Ensure that you don't miss your medication doses. But this is especially true now when we're out of our usual routine. We're home all the time. It's actually probably easier to miss medication doses. So we need additional reminder systems, checklists, making sure that we have alarms or different ways that we're able to make sure that we're not missing medications. Many of you participated in seizure first aid. So being prepared for emergency means knowing things like seizure first aid, knowing that most seizures are not emergencies and can be managed at home. Having extra medication on hand. So for example, not stockpiling, but ordering through, for example, mail order and having a 3-month supply. There have been instances of medication shortages, but this is typically something that is communicated to the patient. So this is something that you would want to make sure that you inform your pharmacy and your physician about, and inform them right away. If you have problems getting your medication, you want to call the Epilepsy Foundation if you need assistance. This is a 24/7 helpline. These numbers are here in English and in Spanish for you. So call if you need help getting your medications. And always have a seizure action plan, keep it updated, and also make sure that people have a copy. So some secondary consequences about COVID, and I know there's a session on this tomorrow, which goes more into depth on this, but now is a stressful time, and stress looks different for everyone. It can be attributed to loneliness, feeling overwhelmed, all these constant changes in our routine, listening to the news, but we do know that having chronic stress can lower our immunity. So what are some things we can do? Making daily routines, getting up and going to bed at the same time every day, setting regular times to do things. So doing chores, maybe taking a walk, getting exercise in the house, eating at the same time every day, sitting down to eat a meal, trying to build some relaxing activities into the routine, getting some fresh air, taking a break from the news, avoid listening, especially at night, maybe substituting that with some mindfulness techniques like meditation or deep breathing, quiet listening, Tai Chi or yoga. Staying connected. So now more than ever, if we can't see each other face to face, calling family or friends, text messaging or setting up video calls. And if you have a counselor or if you need a counselor, now is the time. So make sure you have these connections and ask if they see patients by telephone or video. So a word about access to care. So another secondary consequence of the pandemic. And so as many of us know, during the height of the pandemic, nearly all elective procedures were on hold for several reasons. One was to save resources for people with COVID-19. So meaning the scarcity of PPE, also the concern that at that time, many patients were on ventilators and in the ICU. So elective visits and procedures were also canceled to lessen the spread of COVID-19. So at this point in time, we're entering now this other wave, and make sure to ask about any procedures to take before going to an appointment. If you're scheduled to be admitted to the hospital, ask to talk to the epilepsy nurse and doctor about what to expect, what precautions will be taken. Most of the time, there's pre-admission COVID testing. How should you prepare for your visit? Is there a chance that it could be delayed, and so forth? If you or your family are at risk for a severe form of COVID-19 because of your age or other health problems, ask to continue telehealth visits unless it's urgent. So given what I said, how do you stay in touch with your healthcare team? Many clinics and offices are rescheduling routine appointments or doing visits by phone or by video. And again, this is done to limit your exposure. So before your visit, call your provider's office to check if the visit is still on and how it will be done. But in the meantime, track your seizures and how you're doing at home, and share this information at all of your visits, whether it's in person or by telehealth. And ask what number to call if you need to talk to your epilepsy team. So some medical staff, nurses, medical assistants are now doing work partially at home. So some triage lines have been changed. So it's important that you understand what phone numbers that you need to call. So thank you very much for your time, and thank you all for having me this evening. And I'm happy if there is time to take any questions. Sarah?
Thank you so much, Danielle. That was incredibly informative. And I know that it answered, I think, probably a lot of questions that people do have. I should have said at the beginning, but for those who are listening and learning along with me, there's a Q&A box at the bottom of your screen where you can put in any questions that you may have for Dr. McDermott. But I have a couple of questions that I wonder if you can answer. And one was related to something that you just said about being in the hospital. And as the director of the EMU, you probably know the answer to this. If someone is in the hospital for an EMU stay, can they have visitors right now with all of the COVID precautions and things that are happening? Or does someone have to be in the EMU by themselves right now?
So that's a really good question, Sarah. And the answer is that it changes from day to day and week to week. And so we had, when you saw that the positivity rates were quite low, we had a more relaxed visitor policy, and it actually depended on which hospital within the UC Health system you were at. So it was different. Visitor policy was different if you were at Anschutz compared to Highlands Ranch Hospital, for example. So because of the number of patients who were being seen with COVID-19. So at this point in time, we're looking at probably restricting our visitor policy further. So to be clear, there are visitors allowed, but they are restricted. Typically they have to be named, and the charge nurse has to know who your visitor is. There was a time where there was no visitor allowed when we had just reopened the EMUs. So people did not have visitors. Fortunately, we got to a point where we do. But I'm not sure if that's going to change.
Thank you. Okay, we've had a question come in asking about whether you think that the high temperatures associated with COVID-19 can bring on seizures.
So I would say that if historically, if that's been a trigger, then I would say, again, I would go back to that slide that I had displayed earlier about illness and COVID-19 and seizure triggers, essentially. I would put this in the whole, what is an independent seizure trigger and how does that relate to COVID-19? So there's not thought to be that, so if fever has been a independent risk factor for a person, which is typically related to the acute immune response, then I would say that that could be, for that person, a trigger. I would not relate that independently to COVID-19. I would say that it's related to the acute illness. In children, which I'm not a pediatric epileptologist, but that's a whole different issue, and I will defer.
Do you know, is there evidence that someone who has had COVID-19 once can get reinfected with it again?
Yes, that can happen.
Okay, we've had another question that says, is epilepsy considered a higher risk or only age-related and other pre-existing conditions? Should people with epilepsy be more careful with the decisions that they're making?
So again, epilepsy in and of itself, having epilepsy, looking at epilepsy as a spectrum, it's difficult to put anybody with epilepsy whenever we do anything in a box. And so, it depends on what is the treatment for the epilepsy. So if a person with epilepsy is taking immunotherapy for seizures, that could potentially weaken one's immune system. If somebody with epilepsy has an underlying neurological disorder, which limits mobility. So for example, requires need of a wheelchair, requires need for somebody else to do their activities of daily living, like feeding them or bathing them, then you need to think that that person is going to be in contact with many more people. So it's a matter of contact. If somebody with epilepsy is unable to speak, they may be unable to express the fact that they're ill. And so again, that person may develop symptoms and not be recognized until later on. So it's not the actual seizures, it's what goes with the epilepsy. And so I would say independently, epilepsy is not a risk factor for developing COVID-19 or severe COVID-19. It's all that may be related to someone's epilepsy.
Thank you. For the vaccines that are in development, I know that when medications are approved, they're usually tested in conjunction with a lot of other medications. Is there reason to believe that people who are taking seizure medications would be able to take the COVID-19 vaccine?
I mean, I'm speculating here, but I don't see why they wouldn't be. So we administer vaccines for every other condition for people who have epilepsy and take anti-seizure medication. So.
Someone is asking if, given visitor restrictions, if the Epilepsy Foundation has a resource to help find a place for families to stay nearby while a loved one is in the EMU. And I can answer that question. The Epilepsy Foundation has all kinds of resources to help people with all kinds of challenges. So my answer to that is absolutely. I'm gonna put my colleague Wendy, who you heard from earlier, her email address is caremanager@epilepsycolorado.org. And anyone is welcome to email her at any time with any question, and we can help you with resources like that or like anything else. And we are here to help you with those sorts of things or with anything else, any other questions related to your journey with epilepsy. So absolutely. What other questions? We have a couple more minutes. Does anyone else have any questions? Just throw those into the chat, and Dr. McDermott is standing by with any other questions you may have. People often wonder if the slides that you just saw will be available. This session has been recorded, or is being recorded even as we speak, and we will have this up on our YouTube channel shortly. So you will be able to listen to this again if you would like to, or if you'd like to share it with your friends or family. So this is going to be available afterwards. Any other questions before we end for the evening? Well, I do want to say a huge thank you again to Dr. McDermott for sharing her expertise with us this evening. I want to thank our presenting sponsor, AZI, for their support, and to SK Life Science for sponsoring this session this evening. Thank you all for joining us tonight. This was a great kickoff to our Epilepsy Connect Symposium. So grateful to all of you for being with us and sharing this evening. We look forward to seeing you another evening this week, and wish you all a great night. Thank you again, Danielle, and we'll see you all soon. Have a great night, everyone.
Thank you, everybody.